Welcome, everyone. My name is Chelsea. I'm from Mission Hospital. I would like to thank you for joining us for this webinar. Just some housekeeping, just to let you know, at the end, we will be answering questions. So please keep your questions until the end. And you can raise your virtual hand and we will unmute you to be able to ask your questions. You could also type in your questions in the Q&A box. So I will turn the webinar to Dr. Vora.
Thanks, Chelsea. Thank you all for attending today on the sunny Saturday and taking some time out of your busy day to join us to learn more about Parkinson's disease and deep brain stimulation for Parkinson's disease. I think most of you, or many of you, know me already, but for those of you that are unfamiliar with me, allow me a little moment here to introduce myself. I'm Dr. Vora. I grew up here in Yorba Linda, just around here in Orange County, so local to the area. Did my training, part of my training, like Dr. Taghva, out here in Southern California. Received my undergraduate degree in neuroscience in UCLA. Did my medical school training out here in Pomona. Then I ventured just a state over to complete my training in neurology, neurology residency, and the fellowship in movement disorders over at the Barron Neurological Institute and the Muhammad Parkinson Center out there. And one of the things that I think both Dr. Taghva and myself, share is this passion for deep brain stimulation surgery. Given that both of us, through our training, our respective trainings, we've got a lot of experience with deep brain stimulation and the benefits of deep brain stimulation with Parkinson's disease. And both of us kind of share this vision of bringing that element, our training, our experience to the community setting, because this was something that was previously thought to only be something that could be offered at academic centers, and really that's not the case. I mean, it's something that we think can be offered here at the community setting and really expand the benefits from those historical academic centers. So hopefully today, our goals here today are to share our insights about deep brain stimulation surgery, deep brain stimulation for Parkinson's disease, the benefits, and we'll review a little bit about Parkinson's disease and then talk more about deep brain stimulation surgery. So like Chelsea mentioned, if there's any questions that pop up along the way, please feel free to jot them down or raise your virtual hand, and at the end of the presentation, at the end of the webinar, we'll be happy to answer any questions that you may have. So Parkinson's disease, just a little bit of background about Parkinson's disease. It's the second most common neurodegenerative disorder in the world. There's about 1 million cases in the United States as of 2016, although that number is felt to be a little bit underrepresented in the true amount of cases. We feel that it's an underdiagnosed disease still. There's about 60,000 new cases per year, about 10 million cases worldwide, but it is something that is growing as the population grows, as the aging population grows. It is a disorder that increases in prevalence with age. So about 1% of patients 65 and older will have Parkinson's disease, and about 5% of those age 85 and older do have Parkinson's disease. So it is something that we're seeing more and more. And what causes the disease? What causes Parkinson's disease? Well, we know that it's a dysfunction of dopamine-producing cells in the brain, and that's what's seen here. The cells that produce dopamine in the brain are these cells here in the substantia nigra. And what we think happens is that this abnormal protein, now called alpha-synuclein, grows, aggregates, propagates in an abnormal way, and that leads to cell dysfunction of these energy-producing cells within the neurons, within the brain cells. And that's what leads to selective dysfunction, destruction of the dopamine-producing cells in the brain. And what we see here on the right here is another way to kind of measure those dopamine-producing cells in the brain. And on the left here, we see normal uptake of those cells, and that's what's seen here, these comma shapes that light up normally. And on the right, what we see in Parkinson's disease is loss of those dopamine-producing cells, so you see less lighting up of those areas of the brain. And there's various theories about why that abnormal protein occurs. Some people propose that it may be something from the gut that allows for inflammations occur in the gut and then allows for deposition of the protein and upwards migration from the vagal nerve into the brain. Now there's the evidence to support this theory and evidence against this theory, so it's still something that's being elucidated. But ultimately, when we have less of those dopamine producing cells in the brain, it leads to symptoms that we've come to know in terms of the hallmark features of Parkinson's disease. And that's what we characterize as bradykinesia or akinesia, the slowness of movement, the lack of movement, tremor, typically a resting type tremor, rigidity or stiffness of muscles, as well as gait and balance challenges. Those are the hallmark motor features of Parkinson's disease. But we've also come to find out that there's a lot of non-motor features of Parkinson's disease here. And I won't go through all of them, but this is a pretty comprehensive list of some of the non-motor features. Some of the common ones that we even see sometimes well in advance of the manifestation of the motor symptoms include the sleep behavior disorder, the disturbance during sleep, acting out of dreams during sleep, talking during sleep, loss of sense of smell, and oftentimes also issues with the GI tract, particularly constipation. And this is just another graphical way of representing those features. Sometimes we even label those non-motor features when they occur in advance of the disease, in advance of the motor manifestations of the disease, the prodromal stage of Parkinson's disease. So sometimes that even happens early on before the actual motor manifestations of Parkinson's disease. And generally, by the time the motor manifestations, the stiffness, slowness, tremor, gait balance challenges are appearing, that's already when there's already significant cell loss in the brain, about 50% or more loss of the dopamine producing cells in the brain. Now, Parkinson's disease remains a clinical diagnosis, meaning it's based off of the symptoms, based off of the examination and the history of the symptoms. But there is a scan that we can use to help with diagnosing Parkinson's disease. And that's what this DAT scan is that I alluded to earlier. So once again, on the left, this would be the normal uptake of the dopamine producing cells in the brain. And that's the normal appearance of it. But in Parkinson's disease, there's less of those dopamine producing cells, and therefore we see less of that uptake as represented here on the scan on the right. Now, what does dopamine do? So dopamine is this neurochemical neurotransmitter that is involved in cell signaling between the brain cells, the cells involved in the motor circuitry in the brain. And that's what we see here represented by these little green dots. That represents the dopamine. So we have medications when there's less dopamine being produced by the brain itself. We have medications that can come in and kind of mimic or replicate the activity of dopamine. So the mainstay in treatment of Parkinson's disease is Levodopa, which gets converted into dopamine in the brain. But there's other medications as well, like dopamine agonists represented by the blue dots here, which kind of trick the dopamine receptors in the brain to thinking that there's more dopamine there. And then there's other medications which prevent the normal degradation of dopamine here in the cleft between the two cells, and other medications too that work in a different mechanism. And here's a little graphical representation of kind of the history of medication development with regard to treatment for Parkinson's disease, some of the therapies that are available. So really it was in the 50s, 60s, and then in the 70s where Levodopa became kind of the mainstay in treatment of Parkinson's disease and really revolutionized the treatment of Parkinson's disease. And since then, as you can see, we've come a long way. There's a lot of other medications as well that we now use in the treatment of Parkinson's disease, including over the past 5 years, development of extended release formulations of Parkinson's disease, development of a pump for Parkinson's disease, as well as an inhaled form of Levodopa, and some novel mechanisms, as well as novel treatment therapies as well, including Neurians most recently, which acts on the adenosine receptors in the brain as opposed to the dopamine receptors in the brain. Now, medication works generally pretty well up until a certain period of time with most people with Parkinson's disease, and there's a variety of factors for why there may be a loss of efficacy of medication, of oral medication in particular in Parkinson's disease. And we do know that in Parkinson's disease, it's important to remember that there's progressive loss of those dopamine producing cells in the brain. So there's less and less cells in the brain that will make and store the dopamine. And then there's also progressive changes in the GI tract in Parkinson's disease. And so if you think about it, the medications that you're taking orally, they may not be as well absorbed There may be issues with constipation or slow transit of the GI tract, reduced gastric emptying, things that may delay the efficacy and delay the absorption of the oral medication. And that sometimes results in the issues that we have with medication being as effective as it once was, early on in the disease compared to later on in the moderate or advanced stages of Parkinson's disease. And that, what it amounts to is that it leads to these, what we call off times in Parkinson's disease. And so about 50% of patients after 5 years of having been diagnosed with Parkinson's disease may develop what we call motor fluctuations, or times where they feel like their medication's working and they feel great, they're doing well, what we call the on times, and then those valleys in terms of when the medication seems to turn off or not be as effective, and what we call the off times, when the medication drops too low and isn't working as the way it should be. And so that's what's represented by these videos here. So as you can see on the video on the left, this is a patient with a little bit of a tremor, and his tremor and his gait, his balance is very good when he's on, when the medication's working fine. But when the medication turns off or it drops too low, then you see that his gait is not quite as fluid, his tremor is more predominant during that setting. And then about 50% of patients with 5 or 6 years disease history of Parkinson's disease do also develop these involuntary movements as a result of levodopa, what we call dyskinesia. So if you've ever seen Michael J. Fox, particularly when he's on television, he has these wiggly, squirmy type movements, and that's what's represented here in this video on the right, the dyskinetic type, wiggly, squirmy type movements, which is sometimes, occurs with those on dopaminergic therapy for Parkinson's disease. And this is just another graphical way of representing what happens as Parkinson's disease progresses, as there's longer duration of the disease. We see here that there's less good on time represented by the purple area here under the curve as the disease progresses, and there's more susceptibility for development of dyskinesia, those involuntary movements with medication. And then, as we can see here, there's less on time as well. The time which is represented by the good on time here in the purple area is also less in terms of the finite number of hours where the medication is effective as it should be. And this is just another graphical way of representing those fluctuations and those challenges that we have with medication for Parkinson's disease as the disease progresses. I think this says it best, though. This was actually a patient of mine who submitted this to me to kind of represent those fluctuations, those peaks and valleys, when the medication kicks in and is working well, and then when it turns off in between dosages. And so over here, what we see is when the patient takes his medication in the morning, he has about an hour or so of good on time, and then the medication seems to wear off between the next dose, and that's when there's a reemergence of tremor for this particular patient. Takes his next dose here around 1 p.m. or so, around lunchtime, and then there's a little bit of increase on time now that it's his second dose, but then again it wears off, and there's a little bit of increase in tremors. Again, doesn't quite drop as low as it did for the first valley, given that now he's had 2 doses for the day, and then the third dose is administered, and there's a little bit longer period of on time, and then a dip again towards the evening hours. And so this is not uncommon to have this, as the disease progresses. And one of the strategies is to take more medication and reduce the intervals between dosing in order to allow for a little bit more smoother delivery of the medication. But as we all know, it can be challenging to take medication, especially taking medication 3 times a day or even more, there can be cumbersome. There's also the challenges with less storage of the dopamine cells in the brain, because there's less of those cells to store the dopamine. So there's more of that susceptibility to having those issues as far as the dyskinetic type movements, as well as the fluctuations with the medication. And so one of the therapies that we have to address those fluctuations, particularly those valleys where the medication turns off, is deep brain stimulation surgery. And deep brain stimulation allows for more stabilization of that on time, more preservation of that good on time where the medication is working well. Although this is doing it in a way that's not an oral medication. It's doing it by electrical stimulation of the brain, in order to allow for those peaks to stay more longer in terms of without having those valleys, those dips, those off times. And so that's one of those therapies that we want to talk to you more about today, and hopefully share our insights as well as some patient examples, because we do think it's an underutilized therapy that has a lot of benefits in terms of improving quality of life for those with Parkinson's disease that do experience those particular fluctuations with the medication, as well as a couple other indications for the surgery. So just again, to summarize, deep brain stimulation is a surgical treatment that allows for electrical stimulation to be delivered to specific targets in the brain, and that allows us to help with controlling those motor symptoms of Parkinson's disease. It's not a cure, but it is a very good symptomatic treatment, and it really shouldn't be viewed as a treatment of last resort. In fact, there's increasing data that shows that deep brain stimulation in conjunction with medication improves quality of life measures, improves motor symptom treatment measures more so than each individual therapy alone. And recently, actually within the past 3 months, there's some data from the University of Vanderbilt, which actually they looked at 30 patients or so with deep brain stimulation surgery that had early onset Parkinson's disease, meaning that they had the disease duration for less than 5 years. And they did find some interesting data that may even suggest that deep brain stimulation surgery may slow down the progression of disease, although, that's a study of about 30 patients or so it needs to be replicated in more bigger population in order to see if those promising results hold true. But it is something that is pretty exciting if that does pan out in larger studies. And so once again, the main things that deep brain stimulation can offer is increasing that quality of on time, increasing those on times without those valleys, without those off times, and also allowing for better control of those motor symptoms, so the tremor, the stiffness, the slowness, and helping with keeping that, especially those symptoms that respond to medication, keeping those on time when the medication is acting as it should be, as opposed to when the medication dips and wears off. And I think these videos illustrate it best. So these are all patients that have had DBS, deep brain stimulation surgery for Parkinson's disease. Now this is them with their stimulators turned off. So you'll see their symptoms reemerge as the stimulator is turned off. In the first two cases, you see the prominent tremor when the stimulator is turned off. In this last third case, you see the gait dysfunction, the shuffling, the slowness of movements when the stimulator is turned off. And then in this next slide, we see the effect of the deep brain stimulator as the stimulator is turned back on. And so you see the suppression of tremor as the stimulator is turned on there. You see the steadiness there as the stimulator is on. And in the last case, you see the improvement in the gait function when the stimulator is turned on. Less of that shuffling, better arm swing, better speed of movement. And so once again, that would be the idea with the deep brain stimulator surgery, that it not only improves those motor symptoms, but it also steadies out those fluctuations with the medication. Because it is cumbersome to take medications upwards of 3 times a day, 4 times a day, 5 times a day. And then the medications themselves are not without side effects. And so it is sometimes challenging when there are those prominent fluctuations to address that with medication alone. This is just another graphical representation of those fluctuations. And so who are the ideal candidates for deep brain stimulation? Basically, the main indications for stimulator surgery for Parkinson's disease would be those that have diagnosed Parkinson's disease for at least 4 years. And if they're experiencing those motor fluctuations, those peaks and valleys with medication, if they have a refractory tremor, or if they have bothersome dyskinesias, those bothersome wiggly type movements. The patients that are good candidates for deep brain stimulation for Parkinson's disease should not have any significant medical contraindications to surgery, of course. Outright cognitive impairment would be a contraindication to having the surgery. So those with Dementia, unfortunately, tend to not do as well with the stimulator surgery, so we don't typically offer it to patients with outright cognitive impairment. And the main, things that we see that improve with the deep brain stimulator surgery are those that have improvement in their motor symptoms with the medication, meaning if your medication improves your slowness, stiffness, tremor, rigidity, those symptoms are very likely to predictably improve with deep brain stimulation surgery. The one caveat being that resting tremor, the tremor of Parkinson's disease, does not have to respond to the medication. And deep brain stimulation is pretty effective for those cases where, even in spite of medication, if there is a robust tremor or bothersome tremor, the deep brain stimulator surgery is still very effective for those patients, even though they don't respond to the medication. And next, I'll turn it over to Dr. Taghva, and he'll share a little bit more insight about the actual surgery and the benefits of the surgery and some of the technical aspects of the surgery.
All right. Good morning. I'm Dr. Taghva. I'm a neurosurgeon based out of Mission Hospital. That was great, Dr. Vora. Thank you. So typically when I've given these webinars, I either am slotted to start right before lunch or right after lunch. So I either get a hungry audience or a sleepy audience. So I just bear with me over the next few slides, and I promise I'll get you guys back to your lives. So I appreciate you guys sharing your Saturday morning with us. Okay, so a little bit about me. Grew up in Las Vegas, Nevada. I did my undergraduate work at USC and then my medical degree at the Johns Hopkins University School of Medicine out in Baltimore. I came back to Southern California to do my residency in neurosurgery at USC. And during that time, I was able to spend a year doing a fellowship in neuromodulation, the large part of which was specifically deep brain stimulation at a very busy program at Ohio State University. Part of the reason I bring this up is it turns out I actually am the only fellowship trained DBS surgeon in Orange County. And I've been here doing DBS at Mission Hospital for roughly the past 8 years. And, we've really seen over that time period that we've really been able to keep ascending with regards to the program. And the addition of Dr. Vora has really taken things to the next level in that he's bringing his experience from probably the premier DBS program in the country at the Barrow. And so what we are able to offer now is basically world-class treatment in the community setting. I'm very proud of our record as far as DBS as well. And over this period of time where I've been performing DBS at Mission Hospital, we've had actually 0 infections. We've had very happy patients. And, this surgery is something that if I don't mind tooting my own horn a little bit, you do want to have this in the hands of someone who's specially trained for it, because the level of accuracy required to perform this surgery correctly does take some time to learn and appreciate. And one thing we've been very fortunate at Mission Hospital is between Dr. Vora and myself, and with the help of the leadership of the hospitals, we've been able to really integrate the latest in technologies with regards to directional stimulation of DBS and some of the newer technologies that are out there. And we've really seen this pay off in the outcomes of our patients. With regards to deep brain stimulation, while it sort of seems like science fiction in a lot of ways, where we're putting electrodes in the brains of patients to treat a disease, it turns out that this technology has been around for a while. And the reason that's important is it's been validated in multiple level 1 studies to be a very safe and effective treatment for Parkinson's disease. Now, what's really changed is, despite the fact that DBS became a part of our armamentarium for Parkinson's in the 90s is over the last really 5 years, we've seen just an explosion of innovation with regards to some of the abilities we have now with implanting leads that can steer current to minimize side effects and optimize outcomes. And that's really been, a big change over the last 5 years, whereas first 30 years of DBS were actually pretty stagnant. Now I'll show this video as far as how DBS therapy works, but essentially there's two components to a deep brain stimulator. One is a generator, and this generates a electrical signal, and that electrical signal is delivered to a specific part of the brain that we know controls the symptoms of Parkinson's disease. And so basically, with some of the advanced programming, we can really improve the symptoms of patients. And I think Dr. Vora did a great job explaining this, but basically what deep brain stimulation does is it reduces the motor symptoms of Parkinson's by what we believe is stabilization of the circuits. And one way to sort of think about this is that DBS actually sort of acts like an electrical version of dopamine. Now, the main advantage of this is, number one, we don't deal with medication-related side effects, but more importantly, the stimulation is something that's constant, whereas medications, as Dr. Vora showed, have basically on and off periods. And so what DBS is able to do is basically able to smooth out those motor fluctuations. DBS is a reversible procedure in that the stimulation can always be turned off, it can be adjusted. And why this is important is a lot of the early surgeries for Parkinson's disease were lesioning procedures. And what that means is basically a procedure where we would purposefully damage a part of the brain in order to stop tremor. Now, the problem with those procedures is, number one, a lot of the effects tended to be temporary. But number two, if you had an outcome that you didn't want, you were sort of stuck with it. And the programming parameters and the what we're able to do with regards to stimulation keep improving. And so by and large, people view DBS as the standard of care for surgical management of Parkinson's disease. Now, as far as, well, what does DBS treat well? Typically, the symptoms that respond very well to DBS are the symptoms that respond well to the medication therapies, with the exception being tremor, which does respond to DBS even if it doesn't respond to medications. And I think Dr. Vora made that point very nicely. But rigidity, bradykinesia, which is the slowness of movement, akinesia, which is basically not moving, or dyskinesia, which is abnormal movements, these all respond well to DBS. Some of the symptoms that are less responsive to DBS, but maybe on a variable basis, are some of the gait or instability primarily, and some of the cognitive symptoms. Now, many patients do have benefits in these symptoms with DBS, but typically it's not as predictable as some of the other symptoms on the last slide. But what I do normally tell patients is things that improve with the medication do tend to improve with DBS. One of the best things about DBS is its ability to allow us to reduce medication. Most studies show that with DBS, you can reduce your medication somewhat. Conservatively, we say usually patients get anywhere from a 30 to 50% reduction in their medications. Now, this doesn't, you don't typically stop your medications completely with DBS, but you are able to reduce it significantly. Now, just to change gears a little bit, DBS is typically performed in two parts. Part one being the implantation of the wire that goes into the brain, and that's called the lead. And part two is implantation of the battery. Now, one thing that has really, I think, distinguished Mission Hospital from our colleagues is that we now are able, in select patients with Parkinson's disease, to implant these leads completely under general anesthesia. And the things that have allowed us to do that, number one is the advanced intraoperative imaging that we have now at Mission Hospital with O-arm scanning in the OR, which is basically a CT scanner that can be placed in the OR. And the other thing is our ability to use directional stimulation, which allows us to really steer current. And other advancements are high quality MRI, which give us basically sub-millimeter resolution of the targets we're aiming our DBS towards. The typical target for DBS is something called the subthalamic nucleus, or STN, and that's really about the size of a pea. And so it's really important that we have great imaging, we have intraoperative verification of the wire being in the right place with our intraoperative O-arm, our CT scan. And so now, in some patients, we are able to implant these wires completely asleep. Now, this is the view. So this is the O-arm, which is basically the intraoperative CT scan. And basically, we have a small microdrive, and what that allows us to do is to 1/10 of a millimeter accuracy, place these wires in the correct place. Once the wire's in the correct place, we confirm the placement by getting a CT scan in the operating room with the patient asleep, and then we merge that with the patient's preoperative MRI, and that allows us to know exactly before we leave the operating room that the wire's in the correct place. Now, stage two is, so stage one, the common questions are, how long does it take? And typically, if we start surgery at 7:30 in the morning, patients are typically out by lunchtime. And usually there's about a one-night overnight stay in the hospital. Stage two is where we connect the wire to the battery. That is performed as an outpatient procedure, and it takes under an hour. So after the implant, typically after the initial lead placement, the placement of the wire in the brain, we start programming and turn on the device about anywhere from 3 to 5 weeks after the procedure. Now, the reason we do this is placing the DBS lead itself, placing the electrode in the brain without turning it on, surprisingly actually gives patients symptom relief for anywhere from 1 to 2 weeks. So what happens is patients have an initial improvement in their symptoms just from placing the wire in the brain. Now, and that's called a lesional effect. And that wears off over the course of 1 to 2 weeks, at which point we implant the battery and then we turn it on about a week later. Now, the reason we do that is so we give the brain a chance to get back to its normal state before we program. That way the programs are really optimized for the stable state of the brain. Now, even though we get great results typically with our initial programming, there is optimization that happens over the course of a few months. And part of the reason for this is, one, optimizing the stimulation from the DBS, but the other is, over this period of time, Dr. Vora would be reducing medications or adjusting medications, and the amount of stimulation we can deliver will change based on that. This is a patient of Dr. Vora's and mine who was recently implanted, and this is his initial programming. So you can see before we turn the DBS on, that's his tremor on the left side, and we're going to, okay, and that's DBS on. So basically what you see is his tremor immediately stops. And, you know, at this point, he was sort of shocked by it.
Simmer there for a second, and then we'll see how you're doing here.
Like that.
Yeah, the power of a little electricity. Yep.
So you can see that's a pretty dramatic improvement in the tremor. And again, some of the things we're able to offer uniquely at Mission Hospital are directional leads and a lot of different programming options to give patients more on time. And these directional contacts also allow us to limit side effects, and so it really makes this a very durable long-term therapy. And typically, we tell patients that the results of DBS really are long-term. So the data shows they last, you know, upwards of 10 years, if not more. Now Parkinson's disease tends to be a progressive disease, but it turns out even though the disease progresses, DBS still remains effective. Now, as far as cost and coverage, almost all insurances do cover this. And in my office, we have liaisons that can help navigate this process, although typically this is fully covered by insurance. Okay, so I will stop there, and we'll open this up to questions.